Pleasant morning to everyone. Today I am going to talk about the basics of performing a cardiac CT. I am Dr. Pudhiavan, consultant cardiothoracic radiologist from Koi Medical Center and Hospital, Coimbatore. So the objectives of this talk will be to give you an overview of patient preparation, the different gating techniques, the scanning protocol that we follow in our institute, and the various reconstruction methods. Coming to patient preparation. First, foremost, assure the patient that CT is a non-invasive diagnostic procedure and that it does not take a long time to perform. Patient anxiety is one of the most important factors which increases the heart rate and gives a poor quality scan. So try your best to allay the anxiety of the patient. 4 hours of fasting to solid food. No need of any absolute fasting. The patient can take liquids. Tell the patient to avoid smoking and caffeinated substances which can increase the heart rate. And the patient should be clearly informed that he might experience a sensation of warmth when the contrast is fastly injected through his veins. Contraindications. There are several contraindications, especially to the drugs used when we are performing a CT coronary angiography. The first and foremost is the iodinated contrast. Presence of renal insufficiency with an EGFR of less than 30 ml is a contraindication to give contrast unless you have a specific go ahead with the from the nephrologist. Previous history of contrast allergy, especially contrast related anaphylaxis. Mild contrast related reactions are not a contraindication anymore. Metformin is kind of a dicey thing. If the EGFR is normal, you can just go ahead and do the scan. If the EGFR is low, then it is advisable to discontinue metformin for 48 hours. Beta blockers, which are given to reduce the heart rate, is contraindicated in patients with COPD and asthma, where they can go in for bronchoconstriction, though these are less severe with the newer selective beta blockers. Hypersensitivity to beta blockers is a contraindication. Then presence of third-degree heart blocks and severe hypotension. Again, beta blockers cannot be given. Nitroglycerin is usually given to all patients who want to do coronary angiography in CT to give good distension of the coronary arteries. It is contraindicated in patients who have history of intake of phosphodiesterase inhibitors like sildenafil, patients who have severe hypotension or severe aortic stenosis or hypertrophic obstructive cardiomyopathy. Coming to the venous access, an intravenous access is preferably established in the cubital vein. An access site in the right arm is preferred to the left arm. This is because of the shorter transit time of the contrast from the right arm into the right atrium. When we are giving from the left side, it has to cross the midline. Also, it produces some amount of streak artifacts in the left subclavian vein, which may interfere if you are evaluating the lima origin in post-CABG patients. An 18G or larger cannula is preferred because we give contrast at a faster rate of around 5 ml per second. Breath hold, give a clear instruction to the patient to hold his breath or practice it prior to the scan so that the patient knows what is proper breath holding. And if the patient is unable to hold breath properly, the breath hold capacity can be improved by pre-oxygenation. And also inform the patient that they have to hold the breath with submaximal inspiration. Don't hyperventilate. Coming to heart rate control, this is essential for improving the image quality, and a good stable low heart rate will give you a good images with single segment reconstruction. Also, the radiation dose comes down drastically if the heart rate is well under control. This is because with an increasing heart rate, the diastolic time of the cardiac cycle reduces, and we'll be forced to cover both the systole and the diastole of the cardiac cycle to get good quality images. However, with faster CT scanners, patients with a heart rate of more than 100 can also get good diagnostic quality images. So this is a particular case where the heart rate was around 125. Symptomatic asthmatic patients, so beta blockers could not be given, but still we could get good quality images in a third generation dual source scanner. Coming to medicines for heart rate control, beta blockers is the mainstay. You can give metoprolol 50 milligram oral, or it can also be given IV. Or esmolol is another drug which is selective beta blocker again, and which can be given as an IV infusion. Ivabradine is a specific drug which inhibits SA nodal pacemaker current, and it has a longer duration of action. So it can be given in elective coronary angiogram patients the night before the scan and in the morning of the scan. Beginning with oral beta blockade, and if it is not controlled, then switching over to IV beta blockers is the most common approach. Threshold of up to 70 beats per minute of heart rate, you can almost always get good quality scans with a conventional 64 slice scanner. Coming to patient and ECG lead positioning, examine the patient feet first because it provides better access to the patient than with the head first positioning, and also helps in patients who are a little claustrophobic. The arms are comfortably placed above the head to improve the penetration of the chest by the X-rays, and this also reduces artifacts as well as radiation. Using additional conductive gel and shaving off the hairy areas in the chest will improve your ECG quality. And ECG electrodes are attached in the supraclavicular fossa and below the level of the diaphragm so that it doesn't interfere within the FOV of the heart. And a stable reading of the patient's ECG with clear identification of the R wave is a prerequisite for successful ECG gating. As you can see here, we have a stable heart rate, the QRS complex is well defined, and this will give you a very good ECG gating. Coming to types of ECG gating, there are two types of ECG gating, retrospective and prospective. So retrospective gating, here the tube current is applied during the entire helical acquisition of the cardiac cycle. And in retrospective gating, the tube current can be switched on throughout the entire cardiac cycle with the same current, or it can be modulated so that higher current is given during diastole to get diagnostic quality images, and in the rest of the phases, the current is reduced. So this is called as a modulated retrospective gating. And when the heart rate is very high, as you can see here, so this is a type of modulated retrospective gating where you give maximum current in diastole and reduce the current during systole. But when the heart rate increases, you are forced to include both the systole and diastole to get good quality images. So the scope for reducing the current during the cardiac cycle also reduces. Prospective gating is done using axial step and shoot scans where the entire heart is covered, but only during a particular part of the cardiac cycle. So this is called a step and shoot scan because the tube current is switched on during a particular part of the cardiac cycle. Then the table moves and covers the next part of the heart in the same cardiac cycle, and so forth. The entire heart is covered. Coming to the differences between prospective and retrospective gating, in prospective gating, the data is acquired in a single predefined phase of the cardiac cycle, whereas in retrospective gating, the data is acquired for the entire cardiac cycle. And the X-ray beam is turned on only for a short portion of the cardiac cycle in prospective gating, whereas it is switched on throughout the cardiac cycle in retrospective gating. Prospective gating uses an axial step and shoot acquisition, whereas retrospective gating uses a spiral or a helical acquisition. Functional assessment is possible because the entire cardiac cycle is covered in retrospective gating, whereas it is not possible, especially when you're using a lower generation scanner. And the table movement does not occur during image acquisition because when the tube current is on, the table is stationary in prospective gating, whereas in retrospective, since it is a helical acquisition, the tube movement occurs throughout the time the tube current is applied. And by default, the radiation exposure is little lower in prospective gating compared to retrospective gating. But however, you should be careful that the difference between prospective gating and retrospective gating is getting increasingly blurred with the availability of the newer wide z-axis coverage scanners, which can include the entire cardiac cycle in a single rotation, and also the ultra-fast third generation dual source scanners, which can cover the entire heart in a single heartbeat. Coming to radiation and contrast dose, a typical 64 or 128 slice scanner gives a radiation dose of around 5 to 10 millisieverts for a CT coronary angiogram. However, the newer generation scanners are capable of doing a CT coronary angiogram with a radiation dose of less than 1 millisievert. And in patients with low and stable heart rates, the radiation exposure of CT is lower than that of in the alternative diagnostic tests that are available now. Contrast volume, it depends on the scanner you use. In newer scanners, much less contrast is used, around 50 ml. whereas in a 64 or a 128 slice scanner, you will need to use around 70 to 80 ml of contrast. So this is again another CT coronary angiography in a patient with a stable low heart rate. So this good quality CT coronary angiography was obtained with a radiation dose of less than 1 millisievert. So as you can see here, the DLP for this cardiac scan was only 68.8, which means that the radiation exposure to the patient for this CT coronary angiography was less than 1 millisievert. Coming to the scanning protocol, the scanning protocol consists of first two topograms, the AP and lateral topograms, which helps in accurate planning. And this also helps in identifying the KV and MAS required for this particular patient by the system. The typical anatomic scan range for these patients will extend from the level of the carina. So as you can see here, this is the carina. So the scan range is from the level of the carina covering the apex. So the lateral topogram also, you'll have to see that this is the left dome of diaphragm, the right dome of diaphragm, which is at a slightly higher level, and the apex is lying on the surface of the left dome of diaphragm, so that you cover the heart so that the covering plane is just below the left ventricular apex, so that you don't cut a part of heart while scanning. Coming to scanning parameters, always use the thinnest possible collimation and the fastest gantry rotation time permissible in your scanner. So in this particular scanner, so we have selected a collimation of 0.6 millimeter. Most modern day scanners have auto KV and MA, so you need not worry about which KV to use. So in this particular case, a KV of 90 has been selected automatically by the system based on the AP and lateral topograms. And for reconstruction, always use the thinnest possible slice thickness that is available in your system. In this case, it is 0.6 millimeter, and a slice increment of half of what is the slice thickness. This is because when you keep a slice increment of half of the slice thickness, there will be overlapping data between your axial slices, and this will result in a good quality curved NPR images when you're doing post reconstruction. The first scan in the CT coronary angiography is the plain scan, which is called calcium score. So it is always performed with a prospective triggering without any contrast administration during end diastole over several heartbeats. So the scan range required is as for CT coronary angiography from carina to the apex. And a calcium score is not really necessary in a patient who already has a coronary stent or in post-CABG patients. Coming to timing the scan, bolus tracking method, there are two types you can time the scan. One is bolus tracking and the other is the test bolus method. So in bolus tracking, what you do is you inject the contrast, do an axial section at the level of the MPA bifurcation, keep on repeating the scan so that you track the contrast bolus that is coming into the veins and into the heart and into the great vessels. Whereas in test bolus method, you inject a small amount of contrast before the study, do the same thing and measure the time taken for the contrast to reach the great vessels, so that when you do the proper CT coronary angiogram, you give the same time as the scan interval. When you're keeping the ROI for bolus tracking method, you can either keep the ROI in the descending aorta or in the ascending aorta. If you're keeping it in the descending aorta, a HU of 150 to 200 is ideal for triggering the scan, whereas in the ascending aorta, it is around 200 to 250 HU. So this is a typical bolus tracking method where you can see that an ROI has been placed in the descending aorta and the contrast is slowly coming into the SVC, into the pulmonary arteries and into the aorta. A trigger value of 150 is kept so that the scan is triggered once the density in the aorta moves above 150. So you can also keep the ROI in the ascending aorta, but we prefer doing it keeping it in the descending aorta. And the main reason is that when the contrast comes through the SVC, as you can see here, there are sometimes a lot of streak or beam hardening artifacts that are produced by the dense contrast in the SVC. This can prematurely trigger the scan if the ROI is in the ascending aorta, giving you poor quality scan. So for this reason, we usually prefer keeping the ROI in the descending thoracic aorta. Coming to contrast protocols, there are three types of protocols: monophasic, biphasic, and triphasic. Monophasic is when you have only a single head injector. So you don't have the option of two heads, one with contrast and one with saline. So the problem with monophasic injection is that there will be a lot of streak artifacts in the right side of the heart. Biphasic is the most commonly used, where contrast is followed by a saline chase, so that you get a good opacification of the left side of the heart, while the right side of the heart is not opacified, giving you good control over the density of the coronaries. Triphasic is not very commonly used. It is mainly used when you want to opacify the right heart also to look for any right heart pathologies, where you inject contrast and it is followed by injection of saline contrast mixture. Coming to obese patients, obese patients are always a problem in CT coronary angiography. So in these patients, what you can do is increase the MAS, keeping the FOV smallest as possible. Use a higher KV, 120 or higher. Slow down the gantry rotation time so that the photon flux and the energy of the X-rays are more. This results in a higher signal to noise ratio. Use a contrast media which has the highest available iodine concentration, like 350 to 370 milligram of iodine per ml. And faster flow rates will also use to compensate for the higher image noise in obese patients. Coming to cardiac phase reconstructions, so it can either be automated or manual. Automated is where the system itself determines which are the best phases for assessing the coronaries, gives you two sets of best diastolic and best systolic images. Manual can be done in two ways, either as a percentage of phase, where a well-defined percentage of cardiac cycle is given to reconstruct, or as a time of phase, where a temporal distance in milliseconds from the preceding R wave is given for reconstruction. ECG editing is done when there is a lot of arrhythmias and the system picks up a ventricular premature contraction as a R wave. Then you can use ECG editing to get good quality images. And when you cover the entire cardiac cycle in retrospective gating, the data can be also used for functional analysis. Choosing the optimal reconstruction window. A phase with the minimal cardiac motion is always used for the reconstruction window, and this will be a late diastolic phase in most of the patients where the heart rate is low. The second most optimal reconstruction window will be a late systolic phase, something around 30 to 40% of the RR interval, and this will yield a good quality images. The late systolic phase will yield better diagnostic images than the late diastolic phase, especially when the heart rate is very high. And in patients with severe arrhythmia, an absolute reconstruction method like giving a value in milliseconds from an R wave will give you superior image quality than using a percentage of RR interval. So this is small recording of the phase reconstructions that we do. So in this particular patient, the scan is already over, and you can see that the scan has been acquired over 3 RR intervals. And the system has already determined which is the best diastolic and the best systolic phase and given the images. So what we can do is, if we are not happy with these images or the images are not good, then you can do extra reconstructions. And these extra reconstructions can be done either manually with either using a millisecond recon or a percentage recon. So what you do is you either give a particular percentage of the RR interval to do recons at which the cardiac motion will be least, and or you can also give a millisecond value. You determine which is the best phase by going through the functional data of the patient, where you cover the entire cardiac cycle, go through the images in the functional data, find out the phase at which the cardiac motion is the least, and do reconstructions at that particular time. So to summarize the talk, the first and foremost is reassuring the patient that the examination will be short and uncomplicated. Place the patient in a comfortable supine position. Check the heart rate and rhythm. Consider beta blockers or ivabradine if it is necessary. Place the ECG electrodes and obtain a very good QRS complex. Plan the scan range appropriately and adjust the scan and contrast agent parameters depending on the patient. And administer nitroglycerin sublingually in all patients. This will give you good coronary distension. Provide proper breath hold training, because poor breath hold in an otherwise proper scan will still result in an undiagnostic study. Repeat the beta blocker intravenously if it is necessary. Sometimes the patient's heart rate is stable outside, but on the gantry, the heart rate shoots up. So you can give IV beta blockers, which is a very short-acting and safe drug. Inject contrast agent. We usually use bolus tracking method. And after performing the scan, always make sure that the patient is feeling fine afterwards and look for any contrast reactions. And thank you very much for patiently listening to this talk. I thank IRA for this opportunity, and thank you very much.